Hello, this is Monica Donahue with the answers for questions 65 through 102 on the OST 148 Chapter 7 Study Guide. Question 65. What symbol is used to represent an add-on code? An add-on code is a plus sign. Question 66. Can an add-on code be first on a claim form? Add-on codes can never be first on the claim form. It's always the bridesmaid, it's never the bride. And the add-on code can only be used with certain primary codes or parent codes. It has a chaperone that must be with it. Can an add-on code be used with any CPT code? No. The code or codes that the add-on may be used with are not always immediately above the add-on code. An example of this is in the chemotherapy and infusion of the medicine section. Question 68. Besides the add-on code, what are the other CPT symbols and what do they mean? 3 of these symbols identify information that is either new or changed since the previous version of the CPT and might require a change in office procedures. A bullet represents a code that is brand new. It's a new entry in that year's CPT manual. Question 68. An upright triangle preceding a code indicates that the code description has been revised since the previous edition. Question 68 again. Facing or horizontal triangles. A right-facing triangle preceding a section of text and then a left-facing triangle at the end of the section indicate a change in that text passage. It's a change in the instructional notes. The other symbols identify codes that are different in some way from the other codes in the book. When using these codes, it is important to recognize this distinction and take appropriate action. A forbidden symbol, a circle with a line through it, looks like the opposite of a do not enter sign, is used to identify a modifier 51 exempt code. So don't add 51 to that code, just don't do it. It's forbidden. The lightning bolt symbol indicates a code for a drug or vaccine currently pending approval by the Food and Drug Administration, the FDA. And the third-party payer may or may not reimburse this charge. A hashtag, hash mark, pound symbol, or number symbol indicates that a code is out of numeric order. The AMA did not want to renumber codes, but thought it made more sense for a code to be with its companions. The star is used to indicate telemedicine codes, those services that can be delivered using two-way, real-time, interactive telecommunication systems between the provider and the patient. Question 69. When it comes to E&M codes and/or claim forms, what do POS and TOS stand for? POS is place of service. TOS is type of service, not time of service, type of service. Question 70. True or false? If a service or procedure has a Category 1 CPT code, it will be reimbursable by third-party payers. Well, the answer is false. Not all procedures are covered under health insurance plans. Question 71. What are the guidelines and where are they? And which sections have them? Well, the guidelines define terms and explain the assignment of codes for procedures and services located in a particular section. These guidelines will be before the section. And all CPT sections have guidelines. So there will be a few pages in front of the E&M, anesthesia, surgery, radiology, path lab, and medicine sections that are called guidelines. And the guidelines apply to all the codes in that section. 72. True or false? All payers follow the AMA's coding guidelines. Well, unfortunately, false. As a case in point, Medicare will no longer accept consultation E&M codes because it felt there was widespread abuse. You can imagine a consultation code pays more than a regular office visit. Question 73. What are some of the things that will determine what kind of E&M code is needed? Well, you need to know if someone's an inpatient or an outpatient. Patient status can make a difference, such as are they a new patient, an established patient. The age of the patient might make a difference, like newborns and preventative medicine codes. The place of service, a hospital, the office, can change your codes. The type of service, is it preventative medicine, is it critical care, and the time for the service. How long did it take? These are all some of the things that will determine what kind of E&M code is needed. Question 74. What age group has a special set of E&M codes? Newborns have their own CPT codes. Question 75. What are the key components of an E&M? They are history, exam, medical decision making. Question 76. What are the parts of a history? For this class, there are 4 parts. CC, the chief complaint. HPI, the history of present illness, not past illness, present illness. The ROS, review of systems, not symptoms. And the FISH or PFISH, past family social history. Question 77. Where can you find out the difference between a problem-focused, an expanded problem-focused, a detailed, and a comprehensive history or exam? If you will go to the E&M guidelines, they will explain the difference between these. Question 78. True or false? All observation codes are between the range 99218 through 99226. Well, you need a CPT to answer this, but the answer is false. The code 99217 is observation care discharge, and it is in front of the admission for observation codes. Question 79. What kind of E&M codes are used for routine physicals or well baby visits? Those are preventative medicine codes. Do not use normal routine office visits. Use a preventative medicine code if they're there for a physical. Question 80. To use critical care codes in the CPT, the patient must be unstable, They are ready to leave this lifetime, or they might stay with us. And the physician is in constant attendance. The physician might be on the floor working for that patient, but as soon as that physician leaves the hall, goes to the stairs, goes to the bathroom, the time stops. And so please use these words exactly. The patient must be unstable and the physician in constant attendance. Question 81, true or false? Use critical care codes 99291 through 99292 for pediatric patients. And again, you need a CPT for this, but the answer is false. Pediatric patients have their own set of critical care codes in the CPT. And they are 99466 through 99476. Question 82. What is a neonate per the CPT? A neonate is a child who is 28 days old or less. So 29 days old is not a neonate. Question 83. Now again, you need your CPT to answer this one. But what codes are used for patients in rest homes? And here's a hint, there are multiple code ranges in the CPT. So don't forget to look at the very end of the E&M section too. And watch out, Joe and Jane may have different definitions of rest home that do not correspond to the usage in the CPT. Question 84. In order, the 3 R's of a consultation are: request, one physician asking another physician for an opinion of the patient's care. Render, the second physician sees the patient and makes a decision about what should be done to treat the patient. Reports must be written. The second physician will send a written report to the first physician, and the patient will continue his or her treatment with the first physician. Question 85. True or false? You may be able to bill for physicians responding to patient emails and phone calls. Well, the answer is true, but the rules are very strict, and the code descriptions must be read very carefully to make sure that you don't unbundle. Question 86. What is or are always included in the surgical package per your instructor? Always included is the local topical anesthesia, the surgery itself, and normal follow-up is always included. Question 87. Per your instructor, what may or may not be part of the surgical package, depending on what the physician does or doesn't do at that visit? The answer is E&M. If the visit is a pre-op clearance, that is included in the surgery package. But if this is the E&M visit where the decision to have surgery is made, that is not part of the package. So the physician did not know the patient needed surgery until the physician examined the patient and documented the key components. So attach modifier 57 if this E&M for decision of surgery is the day before or the day of surgery. Question 88. So how do you tell the third-party payer that the E&M was the visit at which the decision for surgery was made? Add modifier 57. Question 89. What if they deny payment? You should appeal the decision. Question 90. What is the name of the time frame that describes when all postoperative services are included with the surgical package. Well, that is the global period. And the global period could be 0 days, 10 days, or 90 days. Question 91. What is the difference between preoperative, intraoperative, and postoperative? Well, use your prefixes. Pre is before the operation. Intra is within. In this case, it's during the surgery. And post is after the surgery. Question 92. What is the difference between unbundling and upcoding? Well, both of these are fraud. Unbundling, you are charging separately for items that are included in a single CPT code. Upcoding is inflating a patient's diagnosis to receive higher reimbursement. For example, a Medicare patient with angina, that claim will be paid less than a Medicare patient who has a heart attack. Question 93. What is a lesion? A lesion is any disorder or discontinuity of epithelial tissue. So lesions can be on the skin, lesions can be inside the body, the tissue that covers the visceral organs. Question 94. What are the kinds of repair in the CPT surgery section? They are simple, intermediate, and complex. Question 95. What is the proper sequencing for multiple repairs on a claim form? Severity and size are going to impact this decision. Complex repairs will go before intermediate repairs, which will go before simple repairs on the claim form. So the more complicated go first, the less complicated goes last. If you have repairs of the same severity, but they're in different anatomical sites, for example, a 3 centimeter simple repair of the face versus a 5 centimeter simple repair of the torso, the larger repair is going to go first. So the 5 centimeter simple repair of the torso is first, the 3 centimeter simple repair of the face is second. Question 96. When can you add the length of wound repairs together? Well, if they are the same type of repair, the same type of severity, complex, intermediate, simple, and if they are of the same anatomic site as defined in the CPT, then you will add those lengths together and have one code. Question 96. Note the anatomic sites are different for each class of repair. So if you have complex repairs, 1 centimeter on the nose and a 1.5 centimeter on the lips, these are in the same anatomic site per the CPT. You have to look at the CPT to know this. Since they are of the same complexity, of the same anatomic site, you will add these together. So for this, we will bill a 2.5 centimeter complex repair of that anatomic site. So if you have complex repairs, a 1 centimeter on the nose and a 2.5 centimeter on the forehead, these are not in the same family of codes, the same anatomic site. So even though these two are both complex repairs, you do not add them together. and the larger one will go first. So the one on the forehead, the 2.5 centimeter complex repair, will be first on the claim form because it is the larger of the two repairs of the same severity or complexity of different anatomic sites. Question 97. When can you add the length of lesion removal, etc. together? The answer is never. You do not add the length of lesions. Lesions will be coded individually or possibly as a lump sum, such as skin tags. So never add the length of lesions. Question 98. What procedures can't be properly coded until you have been given the final diagnosis? The answer is neoplasms. If it is benign or if it is malignant, that can alter your procedure code choice. So never code neoplasms until you have the final diagnosis. Question 99. What is a panel? A panel is a series of blood chemistry studies that are routinely ordered by providers at the same time for the purpose of investigating a specific organ or disorder. The composition of the panel is very specific and no substitutions are allowed. Question 100. What is a view in radiology diagnostic imaging? Views are studies or images taken from different angles. Question 101. The preferred term for X-ray, the image itself, is today radiograph. Now, it should have been radiogram if medical terminology standards had been followed when this word was coined or created, but no. As you recall, gram is record, graph is instrument to record, graphy is the process of recording, but they ignored the rules, and so the X-ray, the image itself, the record, is a radiograph. And question 102. What does gross mean in the Path and Lab section? Well, it is gross to look at some of these things, but gross means looking at a specimen with the naked human